Uh, it's very nice that our year is getting kicked off by one of our own, Dr. Ben Lees. He's been very excited about this quality improvement stuff, and as you know, he's been doing a lot of things up on the ward as well. So Ben, we can't wait to hear what you've got to say.
Great, thank you. So I'm very happy to be talking about this, so thanks for giving me the opportunity, and thank you for coming. I'm confident that I will be under 45 minutes, so there will definitely be questions or time for questions at the end. So maybe if you have a burning question, just keep it for then. That way I'll for sure get through my slides. So without further ado, I'll get started. So my objectives for today are, first of all, to define quality improvement. It's a broad topic, but as quickly as I can, and then how it relates to healthcare. And I want to convince you that healthcare needs cardiologists involved in quality improvement. And not so much that, obviously everyone needs to be involved, but I want to try to convince the cardiologists in the room that quality improvement is important. And then I want to do an overview of the local efforts and quality improvement projects at RUH that I've been involved in. Obviously, this won't be an exhaustive list because there's a lot of people involved in quality improvement, but haven't connected with all of them yet. So just a bit of background. This year, in addition to doing my cardiology residency, the program has been kind enough to let me participate in this program at the University of Toronto called the EQUIP certificate. And the point is to build excellence in quality improvement in trainees and staff people who want to contribute quality improvement to their local center. And so the program directors are Dr. Kaveh Shojania, who's the editor of BMJ Quality and Safety, and Dr. Brian Wong, who's also a leader in education research in the realm of QI. So continuous quality improvement is a team sport. So it's combined and unceasing efforts of everyone, and that's everyone in healthcare, to make the changes that will lead to better patient outcomes, better health system performance that's measurable, and then better professional development in particular. So just briefly, quality improvement has been around for a while, and there's a history behind how it came to healthcare. But it really gained momentum when the U.S. started focusing on patient safety and published this document, To Err is Human, where essentially it outlined that medical errors are caused by faulty systems, process, and conditions that lead people to make mistakes or fail to prevent them, and that as many as 100,000 people per year in hospitals were dying in the U.S. because of preventable errors. And so this, of course, got some momentum in Canada and in the U.S., and so measuring quality became a priority for hospitals. So measuring quality was to inform hospitals, inform policymakers, inform patients on their outcomes, and on how we were doing, so to speak. And one of our Canadian bodies that deals with all these statistics is CIHI, the Canadian Institute of Health Information, and they focus on these 4 pillars of healthcare: the patient experience, quality, safety, outcomes, and value for money or cost effectiveness. So I want to define a few things because some terms get thrown around. I want to make sure that we understand what we're talking about. So quality control is somewhat synonymous with quality assurance. And this, I want to permit myself to use an analogy that was used at CCC this year, which I thought was useful, is quality control is about keeping the bar set high. So you have a set standard, whether you're a manufacturing company or a healthcare system. And so let's say our bar is, or for the hospital is, okay, we're going to have 42 caths per week. Can't really go above that because we can't afford that, or we can't really go below or whatever. And so this is the data point. So every month you see how many caths are done. And then if you add upper limit of normal intervals, you can see that for the most part we're staying within that range. And so this would be direct feedback for the hospital that, okay, this is where we're at. But it doesn't tell you anything about how to, say, improve the volume of caths or change the volume of caths. And so quality control is strictly concerned with reporting on a set standard. Okay? Now, quality improvement is different because we're not just making sure the bar is at a certain level, right? We're trying to set the bar higher. We're trying to improve standards, finding creative ways to change care delivery and improve the current status quo. And so this is a graph from a manuscript that Dr. Couverette, Dr. Frost and I, and Dr. Bryce and Dr. Lyon submitted for publication, which shows TSH utilization in the CCU over the last 2 years. So we were initially able to prove that physicians order tests based on what's present on the order set. So when we actually removed the TSH box from the order set, we had a dramatic decrease in ordering. And in fact, and I don't want to put too fine a point on this, but all the TSHs that were sent that we reviewed, and there were about 200, did not ever change patient management. And so it's sort of thought-provoking that this test had sort of got us into a habit of ordering a test that we weren't necessarily acting on. And so this is an example of an intervention where we measured an outcome, we're able to look at counterbalancing measures and make changes based on that. And so this intervention, based on our rudimentary cost analysis, saves the unit about $7,000 a year. So I want to caution everyone that quality improvement requires change, but not all change is an improvement. And the whole science behind quality improvement is making sure your change is doing what you think it's going to do. So, for example, what's that? Oh no. There's not very many Justin Trudeau fans in the crowd, so I don't want to sound like him. Yeah, that's right. So I want to underline that bad interventions tend to rush to a solution. So, for example, let's say you have a problem, clinic no-shows. Everybody has experienced that. So at RUH, patients tend to complain about the parking lot, especially if you do outpatients here. And in fact, sometimes they'll even suggest that, oh my goodness, this parking lot's so horrible, I don't even want to come to my appointment. So you might think, okay, well, let's build a less confusing parking lot, and the hospital gets on board. It ends up being a $50 million project, but everyone gets on board because they think that this is going to make a big difference. But it turns out the no-show rate is the exact same, pre- and post-intervention. And so your question might be, well, what went wrong? Why didn't we clearly page this matter to patients? So this is so when you rush to a solution, usually it's lack of literature search and also lack of problem definition, which I'm going to talk about a little sooner. But this problem has been studied. No-shows have been studied. And the major factors are actually patient age, so frailty, appointment lead time, so how long from when you schedule the appointment to when you actually have the appointment, so longer means less attendance, poverty, distance to appointment, and the list goes on. But had these people known this, they might have picked an entirely different intervention. Because as it turns out, not many poor patients have cars. So changing the parking lot has no effect on whether or not they're going to come to clinic. So it's always important to keep that in mind. And Dr. Albert Einstein reiterates this when he says, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem. And once you've defined the problem, you have 5 minutes to think about the solutions because the solution becomes then obvious to you. My wife said my presentation was too boring, so I put this in here. So this is a doctor who has rushed to a solution without understanding the problem. The patient's like, what? So I want to talk about traditional research, sort of the flow of traditional research versus QI. A lot of people will say research is research and QI is QI, and there's no overlap. Well, it turns out there's a huge amount of overlap. So traditional research in its most rudimentary form is essentially you get a literature search or clinical experience, and you generate a clinical question. And if you think you can test that question by controlling variables, you generate a hypothesis, you do a study, get results, and then discuss them. And so we're very familiar with that model. Now, quality improvement is a little bit different because it's a cyclical thing. And it's essentially the overlap of research is in these first 3 boxes. So it's not unlike research in the sense that your problem needs to be well understood. You need to do a literature search. You have a hypothesis for why these problems exist, and you interview people, you figure out what's going on, you directly observe the process, you do lots of things to try to understand your problem. So let's say for the clinic no-shows, you'd interview physicians, figure out what their views are. You would try to follow up with the people who actually didn't come and interview them or try to understand why they didn't come. And then maybe you would directly observe patients in the clinic and understand, what determines whether they're going to come to clinic or not. I guess what I'm trying to say is that each of those specific interventions or each of those specific maneuvers to understand the problem could be a research study on their own. So quality improvement really is a painstaking process to understand your problem. And you could spend years on one intervention. So it's a painstaking process. But eventually you get to the point where you're designing intervention, refining intervention, implementing it, and then measuring it in an objective way. So I'm going to get to some examples of quality improvement interventions just to get you thinking about it. But there's 6 dimensions that have been identified as sort of important quality improvement or areas that can be improved. So safety is one of them, effectiveness of care, patient-centeredness, timeliness, efficiency, and then equity. So I want to give an example of safety. So several months ago, I was helping a resident with a central line. And you'll notice that in our central line kits, the scalpel sort of comes out just like an X-Acto knife. And the resident made their cut and advanced the dilator and then put the scalpel down without retracting the scalpel because that's an active process. But later on, when I was helping with the procedure, as I was helping, I actually got stabbed by the scalpel because I didn't realize it hadn't been retracted. And when I spoke to colleagues, this has happened a lot. In fact, most residents will have a story of at least one time when they've been stabbed by something like a scalpel. And so when I got talking to some of my residents at other centers, their scalpel only deploys with an active process. So you actually push the button and the scalpel comes out. And when you let go, that's when the scalpel retracts. So the passive process is the retraction, and the active process is taking the scalpel out. And that makes a major difference. And essentially, you make the scalpel idiot-proof after that. And it's very hard to hurt yourself with it. What's that? Yeah, potentially. But for central line kits specifically, like all you're doing is a cut. So another example, and I want to thank Dr. Jai and Dr. Idris Barre, who's one of the residents in internal medicine, who allowed me to show this unpublished data about triple therapy prescribing at RUH in 2015. So they looked at cardiology versus CTU, but 56.2% of our HFrEF patients left the cardiology ward at RUH on beta blocker, ACE inhibitor, and MRA. And if you count patients who are not adherent to therapy, it's possible that less than 50% of our HFrEF patients are actually on this triple therapy. And so I want to compare these two groups, CTU versus cardiology, and the prescribing of triple therapy. So first I want to point out there's definitely an age differential between these people. So CTU is a good 10 years older than cardiology, and that's statistically significant. But the other thing that's interesting is that although our prescribing rates are 56%, theirs was 11%. And their rates of follow-up were 16%, and ours were 96%. Now, at face value, you might say, well, cardiology is better at managing heart failure. So that's an interesting thought. But I want to talk about this data a little bit more. So first of all, age did not predict. Oh, yeah, and the last thing I want to say is that there's also a mortality benefit to being admitted to cardiology for heart failure. There was a 40% reduction in heart failure in that population when they were followed up. So interestingly, and I know their age was different, and so that muddies the waters, but age actually did not predict mortality. So even in statistical analysis, doesn't mean it didn't, but in the statistical analysis, age didn't predict mortality. But rather, the strongest predictor of survival was being admitted to the cardiology service. So this raises serious questions. So does the CTU have support of a cardiology consult service if there's difficult patients that need titration medications? Are residents receiving adequate guidance on CTU? Are they being supervised? Are their orders being reviewed? Are these CTU patients on off-service units? And how is that impacting their care? Furthermore, are they more likely to be isolated, which makes physicians less likely to properly examine them every day? So I think this is a very thought-provoking review, and we can draw the wrong conclusions from them potentially. But the other thing that I thought was interesting is that I've never received feedback during my residency about my prescribing habits. I don't know how good I am either. And so this would be the first time that I've ever seen, at this center, an understanding of at least metrics of how well we're prescribing medications. So sometimes I ask myself, why do we fly experts in from all over the country or all over the world to talk about these cutting-edge new therapies and cutting-edge techniques when we haven't necessarily mastered the basics, or at least we haven't demonstrated that in an objective way. So just to give you an example, this 40% difference in mortality, this is basically an NNT of 2.5 or 2. And I know this isn't a prospective trial and there's lots of confounders, but it's just thought-provoking. So hopefully what's that? Yeah, for sure.
You know that retrospect from around 2015, what time frame was that? Because I'm just thinking, previously we would only use spironolactone and, based on rails, right, where your EF was, 35, year class 3, class 4. And I can't remember when the heart failure guidelines changed, where was it around 2014, 2015, where we started using spironolactone for less sick patients?
You still have to have an echo to see what the EF is.
Yeah.
Yeah, but I'm just sort of saying, I'm looking more at us. Like, I'm surprised that we're that low. Cardiology is at 56%. And that's what I'm sort of wondering.
That's across the board, though. That's why they changed the guidelines to say just triple therapy.
Yeah.
No, I know, but I'm just sort of saying, like, if, 56, I think it's terrible for our cardiology ward. I'm surprised it's that low. And I'm just wondering, is that because they're just on ACE and beta blocker and we were not using that?
Possibly, yeah. You're right. And that's, again, and that I should have mentioned that.
Was it 2015?
2017 is when the guidelines changed. Yeah.
That's why they changed. We're not unique. You look at the
Yeah.
Right, I know, but I'm just saying if we at 2015, the guidelines would have said probably double therapy.
You also have a 30% rate of chronic kidney disease, so there is a group of patients who are probably not prescribing for legitimate reasons. Like, you have to look at the sides of who has contraindications to those medications as well. And it's not the remaining percentage of that, but a degree, maybe up to 20%.
Right, and that may explain part of the CTU that they're pooled. And
although the rates of renal failure essentially no different. So it's still, they're way under prescribing, at least on the superficial.
Criteria for a CTU admission is relative hopelessness, though.
Yeah.
Right, like that's the eyeball decision that the ER doctor makes.
Yeah.
I don't think so. I think there's a lot of people that do cardiology go to medicine, but they consult medicine because a senior resident sees that patient quickly and gets them out of the merge. I think that's part of the factor as well.
It is. I'm oversimplifying.
The numbers are not too bad. Like, if you look at clinical trials, you look at beta blockers that use a discharge, about 2/3, 66%. Look at ACE use, about 75%. And so when, like Sarah said, when you take out some of the compelling contraindications, this number comes very close to real life, or even to clinical trial data. And the denominator is only 166, and you push that up to, or drop that down a little bit, and that percentage changes.
Well, we just think we're so awesome here, and that's why I higher than 56%.
One other point is that, a lot of times, because our length of stay is too short compared to that, we may have started these things and planned to add the MRA as an outpatient, and we have a nearly 100% follow on. So, I think that might also reflect something.
Well, I think we have those patients that, we get a little over diuresed aggressively, and then we don't have a chance to get that other stuff on. But luckily, we do hopefully see them for follow-up to make those changes.
Yeah, so that was a great discussion. And it also underlines the point that cardiologists and physicians need to be part of this process of critically appraising this information that's being collected, because the wrong conclusions can be drawn, as you've all pointed out. So I'm really happy that we're on the same page. So the whole point of quality improvement is the interplay between improving patient outcomes, improving professional development, and improving system performance for everybody. And think of how great it would be if all of us got confidential 6-month performance reports on our prescribing patterns or on our readmission rate, so that we could actually critically look at our own performance instead of just guessing at what we're doing. Go ahead.
There actually is a program out there called the Insight program, where you actually, it helps you with your health points, but you have to review at least 10 of your patients in your treatment of heart failure and whether or not place them on the proper medications as defined by the CCS guidelines. And then you actually review all your results. You can put as many patients as you want, but it requires at least 10. It's a little bit labor intensive, but it addresses all those issues about why was this not started, for example.
Right, and that's really cool. And The disadvantage, as you pointed out, of that process is it is labor intensive. So it would be nice if this was built into our workflow. And I'll get to that a little bit later. I want to give or look at another realm of the dimensions of quality, which is efficiency. And this one is what I've been most focused on in the projects that I've been involved with. So this is a cool study from Ontario. And they were looking at what are the rates of normal coronary angiography in Ontario. And when each letter here represents a different hospital. So Q, 75% of the casts that they're doing are normal, whereas 20% in A are normal. And this is an interesting study because it illustrates the concept of variability, which you may have heard of. But variability essentially implies inefficiency because all these hospitals are doing different things, and it's not really clear why. The mean is 40%, which is roughly around the mean in the US, which may or not be useful to be compared to. But the center that's cathing 75% normals in a setting where in a setting where a cath is $2,500 to $3,000, it's hard to argue that that's adding value to their care. And so probably the right number is, somewhere in the middle, but we don't really know. But this variability really suggests that this needs to be investigated. We need to figure it out. And it needs to be led by people who understand the dynamics of why people are cath and why people are not. In the same study, they found that there's a 50% higher rate of normal angiograms in community hospitals compared to academic centers. And so we don't really know why, but a few theories are maybe they don't have as good access to non-invasive imaging. Maybe they don't trust their non-invasive imaging reports. Or maybe at academic centers, we're more rigorous about picking the cathing or who we're cathing. So it's tough to know, but this, again, outlines why it's important to get to the bottom of these trends that you see. So just out of interest, the predictors of a normal cath that they were able to identify include, in particular, the absence of risk factors, but also atypical symptoms and being at a non-teaching hospital. But I thought this reinforced that taking good history is very important, and I thought that was important to share.
Well, as well, we go back to, how do you interpret what is a non-teaching hospital?
Yeah, that's true.
Do they have a critical care unit where you're seeing a lot of, acute coronary syndromes, or does it mean there's some other variable within that, right?
Mm-hmm.
So I think that's part of the problem in interpreting information is we don't necessarily know sometimes what the variability you're examining encompasses. Right?
Yeah. So the next step at this point would be to figure out, how do you define this problem? So who's going for cath? Figuring out which patients, what goes into the decision making, and it's an important process to be led by a physician, in my opinion. So here's another interesting study that was done in New York. These are internal medicine residents. And so they track their test ordering patterns for a year. And you can see they're stratified by PGY level. And so light blue is 1, yellow is 2, and dark blue is 3. And you can see there's enormous variability in how many tests internal medicine residents are ordering. So this person is ordering, I don't realize I don't have, this person is ordering about 2,000 tests per year, whereas this one's ordering 13,000. So the question is, what value is that person adding? Or are they more astute and picking up on more diagnoses? Or are these people right because they're sort of in the mid-range? We don't really know, but we don't have enough feedback and we don't understand internal medicine resident ordering patterns. All we know is that there's tremendous variability. And so that flags that there's probably an issue here that needs to be resolved. So I'm going to switch gears and get you involved a little bit here. So if you were to design an intervention, so let's say we're on the cardiology ward and there's an outbreak, so someone has diarrhea. How do we get physicians to comply with putting on their gowns? What would be the most effective intervention to get people to put gowns on? And if you answer questions, you get chocolates. So. Okay, so that's a good point. So Dr. Chevedia has said, put the patient's excrement at the front door. So everybody sees it, and they put the gown on. Nice work. Anybody else? Any other suggestions? Okay.
Just making it easier to gown, so like the gowns are available instead of like trying to find them on the ward.
Good. Yeah. So changing the flow of the ward. Yeah, for sure. So somebody stands and hold it up. This is for you. Automated gowning system. Okay. Fair enough. Costly, but potentially effective. Okay. Anybody else? Okay. Reminders. Good. Try to get that to you. Okay. There you go. Nice. That's good. I like that. So those are really good ideas, actually. And I'm very surprised no one said an education and training intervention, but maybe that's... Okay. Sorry about that. Okay. So I'm surprised no one said education and training, and I'm actually glad nobody did. And maybe that's because we've been sensitized to the fact that these education trainings don't do anything for us. But it turns out that the more human-oriented your intervention is, the more it depends on the goodwill of the people involved, the less likely it is to work. And so, in fact, no, it's true. And this has been documented time and time again. And in fact, Dr. Pierce and Dr. Chevedia's examples and Dr. Nosib get into this higher, more effective system-oriented intervention where you actually, in Dr. Pierce's example, you can't do your job unless you put your gown on. And so if you can't do your job, you have to do it. And so that's an example of a forcing function. Whereas, I can't remember your name there. Yeah, what's your name again? Nassim, yeah. So Nassim was talking about rules and reminders and stuff like that, and that you can see is more at the bottom. So, yeah, go ahead. Yeah, totally. Good point. Yeah, and that was what Dom's example was also getting at. So this is just to give you an idea that when you've defined your problem, which this is how you do it, you can really think about interventions that are going to be impactful by using this hierarchy. This is Dr. Thomas Marwick, and this is kind of a funny picture of him, but he is the associate editor of JACC and the deputy editor of JACC Cardiovascular Imaging. And he's commenting on how the appropriateness use criteria that were designed for non-invasive imaging have essentially not impacted ordering patterns over the last 10 years. And this, again, lends credence to the whole hierarchy that the whole education and rules is really not that effective at changing physician behavior. So on that note, I want to switch gears to talk about some local things that we've been trying to do here. And again, this isn't an all-encompassing review of all the quality improvement initiatives that are happening, but some of them that I'm involved in. So Kirsten Marshall, me and Dr. Paz Jensen did this review a year or so ago, or 2 years ago, and we looked at ordering of echoes. So 54% of them were ordered by cardiology, which is not surprising. 22% by internal medicine, 12% by neurology, and then 12% by other services. But what we noted was that even though there were a minority of CCU echoes in this population, but still some CCU echoes, the mean wait time for echo was a lot longer for off-service patients. And so, in fact, cardiology-ordered echoes were all done within 2 days. Whereas the echoes that were done in other services, all the ones that were done greater than 5 days were all on non-cardiology services. And in fact, four echoes were canceled, 2 of which were in stroke patients. And they were all off-service patient echoes that were canceled, usually after their echo had been delayed long enough. So we started wondering, why is that the case? So we generated something called a fishbone diagram. So what this is, it's a quality improvement tool. But basically you have your problem. So echocardiograms are delayed on the non-cardiology services. And then you look at patient factors, staff factors, echo-specific factors, or hospital and environmental factors that are contributing to this issue. So I want people to shout out, and again, you're going to get some loot. What kind of things do you think would contribute to why non-cardiology services are not getting echoes as quickly?
Standardization.
Yeah, so triaging, fair enough.
Regional
Okay, can you be more specific?
So the cardiology patients are regionalized who goes into the room.
Yeah.
To go to neuro or
Totally agree. Not far enough. Okay. Anybody else? This is a tough one.
The patient factor, I don't want to talk about.
Okay.
The patient is just multifactorial. It's not a focused cardiac problem. There's
Right.
many other tests that patient has to go for. He's getting a CT, he's getting an MRI. It's not critical for him to get an echo within 2 days.
That's a good point. Yeah.
That is the patient factor. I don't want to talk
Yeah, okay.
the preponderance of patients with MRSA, EFPL.
Yeah, super good point. Yeah.
Anything that would prolong the procedure, for example.
Yeah, absolutely.
Selfishly, the echo department is run by cardiology. We're because we're getting the patients out. We care about our care probably more than we care about the hospital.
Yeah, so relationships are key.
You know, the CT patients are there.
Yeah, yeah. What's that? Yeah. Okay, good. So those are all really good ideas. These are some of the things we came up with, and actually, I think there was overlap with essentially all of them. But I just want to go through them briefly. So proximity to ultrasound was mentioned. Outbreaks are more likely to happen on off-service wards. So again, that isolation piece you're talking about. Patient flow was mentioned. Sheer volume. So there's a large volume, and so we tend to prioritize the cardiology ones because they're more clear indications, and so that's over here. Lack of triage information, definitely. So as you know, the orders that are given right now for echo, essentially all you have to do is write echo and write query, CHF, or you write dyspnea or whatever. So the triaging service, or hyponatremia or something irrelevant. And so very hard to make a decision about whether this patient needs an echo or not. And that is definitely more common on non-cardiac services. The other more echo-specific ones are that ACS echoes are a little more straightforward. So the triage person knows what they're getting. Cardiologist knows what they're getting. It's much easier to push these through. And the perceived need of the echo, and this is what Dr. de Villiers is getting to, does this off-service patient, has hyponatremia, do they really need an echo? And it's not clear. So we tried to address these issues, and I circled all the red ones, which our interventions are hopefully going to address.
I'll just add one thing. I think that relationship is key in that when a cardiologist on the ward calls down to our nurse coordinator and says, I really need this echo because I'm trying to get him discharged or this patient is sick, that patient gets done and that CT patient gets pushed back.
Absolutely,
And not just that, when the cardio ward is full, all the managers know. So then, if more echoes have to be done on 6,000, we get beds freed out or CAS. That happens internally.
Yeah, it does totally. Yeah.
This is more of a question related to your Albert Einstein comment. But is this, and I'm happy with it, but is this really the question? Or is the question that off-service echoes, why they need to be ordered in the first place? When we think about the problem, like what is
You're right.
Is the problem that off-service waits too long, or is the problem that off-service orders?
So you're right. And we looked at those 100 echoes, and I didn't include this, but all their indications were reasonable. We reviewed those charts, and they were all reasonable echoes. And so... Yeah.
And it was more of a global question.
Yes.
Global question, right?
But you're right. You're right. Absolutely right. And so, again, I'm targeting the objective data we have, is that there's a delay. So the question is, why is that? And so that's why we populate these fishbone diagrams to really look at the issue from lots of different dimensions. Yeah. Yeah, this is at RUH, yeah. So a few projects were designed to help address these problems. And so I'm going to talk about all three. So the first one is this focused cardiac ultrasound in stroke, also known as the FOCUS trial, which lots of people have been involved in. But ultimately, when we interviewed the neurologists, they were frustrated because they would cancel their echoes because of long wait times. And really, they just wanted a few simple answers from the echo, and they weren't interested in getting a standard full echocardiogram. Whereas on the cardiology side, the yield on an echo is so low, we would always triage them later because we're like, well, what are they really looking for? Like, does this really make sense to be doing this? So we tried to meet in the middle, and we've designed a focused protocol that takes 10 minutes or so to perform. And basically, the technician goes up with a handheld device. So ultimately, all you're using is 2D and Doppler. and you've positioned patients comfortably, or the nurses on neurology do, on this ergonomic bed for the tech and for the patient. Technician takes a few pictures, answers the questions that need to be answered, and then a cardiologist interprets them. So the advantage of this is it's more comfortable for the patient. You don't waste time transferring back and forth from non-invasive. And plus, you're using a very simple device, and it switches it streamlines care for stroke patients and engages technicians with new varieties of imaging. The other thing I think it does, which we underestimate, is we add value to cardiology because we're adding diversity to the tests that we can potentially offer. And so I think, emergency medicine and ICU have largely taken over this whole focused ultrasound, but I think we have something to offer in this realm because an expert can actually interpret these images, and there's billing codes for this and everything. So we essentially have designed this study to look for these specific things on the focused ultrasound, which this was published by European Heart Journal and European Heart Society, which is basically all the things that would be related to stroke, major and minor risks of cardiac embolus, which is essentially what the neurologists are interested in documenting.
Because that question then, if let's say the patient has a mechanical valve prosthesis, wouldn't they just be excluded?
They're excluded from this trial, yeah. Good point. So we're excited about this project because it's interdivisional between neurology and cardiology. We're officially funded, and there's multiple contributors. And I actually want to take this opportunity to thank everybody who's involved from non-invasive cardiology, Heart Health QI Committee, and the Neurology Stroke Unit, because this is a team effort. And we're going to be comparing this focused ultrasound to regular care. And hopefully we get enough patients that next year, the year after, we can recruit other centers and try to validate this process. So the next part of the fishbone diagram I want to talk about is volume and unclear indication. So when we looked at the 54% echoes that were ordered from cardiology, we noticed a lot of them were ordered for unstable angina. And in the setting of unstable angina, we noted that most of these patients were actually getting angiograms. So I reviewed over a 1-month period about 200 angiograms, and 39 of those were done for unstable angina, which is about 20%. But interestingly, those patients were also getting echoes. And even when the LV-gram was normal, 58% of these patients also were getting inpatient echocardiograms, and most of them were normal. In fact, 95% of the time, EF determination was actually the same in that sample, with the caveat that the confidence interval didn't quite back that number up. But still, over 80% of the time, for sure, they agreed. So what we decided to do was say, well, can we select these low-risk patients at admission and triage them to a track where they get an angiogram and LV-gram, and if that's normal, really, they probably don't need an inpatient echo. And so the clinical nurses on cardiology have been operationalizing this algorithm, and since November 1st, we've actually been able to avoid 12 echocardiograms in those patients. Furthermore, we're following these patients serially, and of course we have ethics and operational approval from the hospital in order to inform this intervention to see how safe it is. But we're pretty excited about this. Some of our barriers to success have been buy-in from the cardiologists, which is part of the reason why this grand rounds has been arranged, is to help us all sort of think about this critically. And then the entrenched culture that all admitted cardiology patients need an echo, which I don't think is always true. What's that?
I think it's your preset order sheet. Like a lot of times these are ordered by the resident, not to slam them. But
that's the intervention that we intervene to that. What's happening is our colleagues, which despite the fact I've discussed this 15 times, now go back and reorder it.
Yeah.
So that's the barrier.
And you're right. And so we looked at that. You're right. We thought the echo was the the order set was the low-hanging fruit. But when Kirsten Marshall and I actually reviewed that data, 50% of residents, only 50% of residents checked it off on a random on the 25 order sets we looked at, and a lot of the echoes were being ordered after. Yeah, and furthermore, when we interviewed residents, they said they were afraid of not ordering the echo because they didn't want to get reamed out the next day. So that's interesting, but we never would have figured that out if we hadn't talked to them. Go ahead.
So just a suggestion in the algorithm, I don't know if you ever thought of it, because it makes an assumption then that you actually have adequate enough patient may need a PCI, for example, you never know that.
Yeah.
The point behind that was that you have the carte blanche to then say, as a cardiologist, the nurse clinician says, "Oh, this fits the criteria. We're not going to order it." So when you come through and you say, "Oh, you know what? That patient's not going to get an LV graft. I'm going to order it." So the algorithms can't be all inclusive. It was meant to be simple, so the nurses can pick this, and the cardiologist is supposed to review it. So the cardiologists have been forwarding them anyways from multiple reviews.
Totally agree with that.
Because we don't have the problem is we don't always have that information. In order to do this, the nurses have to triage it before we start rounds, and they have limited information from the history and physical that is provided from.
It's just that I just don't want to get it lost in the shuffle because, it makes that assumption to actually figure it out.
I find it really interesting because the place where I used to work, there were 2 hospitals across the river, and the practice pattern on this exact issue was very different. So at the academic hospitals, hardly any LV grams were ever done, and most with the rationale that trying to save contrast levels and decrease rates of renal dysfunction, and the fact that they're all getting echoes anyway. So there was essentially
at the academic center.
At the academic center. Then across the river, their practice pattern was largely, they do get an LV gram, but most of these patients did not get an echo in the hospital, and we're getting them. That being said, the echo is still being done.
No,
it's being done outside.
And that's actually what this is about. So what this is saying is that the guidelines don't say everyone needs an inpatient echo. The guideline says patients need an inpatient assessment of ventricular function, right? And so I think one of the other things why there's been trouble with buying from cardiologists is that they make the assumption that this patient's never getting an echo. No, that's not the case. The patient gets me with unstable angina, has a normal LV gram, and someone with a stethoscope listened to their chest and was pretty convinced there wasn't a severe murmur. That patient can be discharged and have his outpatient echo done in your office 2 years later. No, actually, Ben's got pretty data.
Yeah.
I think it's a good point. We have a major demand that we can't meet, and there's patients that do not need an echo.
Yeah.
And that patient who has a murmur will get his echo, or that patient who has a normal cath, and you're stepping back and say, "Am I missing something? Is this a pulmonary embolism?
Yeah.
Something else?" You could still order that echo.
For sure.
I think that's the point behind the QI, right? The QI was to pick something objective that everyone would agree to prove that, exactly what you're saying, that we have a pattern of over-ordering echoes in our cardiology ward, which is a huge problem with flow. It's not only economic, it's the same over Christmas. I did all LV grams for you, so you can discharge the patient, right? And so I think Ben's point behind all this is let's pick something that actually is supported by the guidelines. No, you do not need an echo. I want to say that again. There's nothing in the guidelines saying you need an echo. You need assessment of ventricular function. And you get your echo done down the road.
You might not even need that.
You might not even need an
assessment of ventricular function.
Mr. Speaker, so on the assumption we have a ventricular graft done, is your premise that these people are never getting an echo?
No, they get an echo as an outpatient.
Well, is your clinical
It's up to you. Yeah, it's up to you.
Say, look, this guy's pain was non-cardiac. He's got a normal LV gram, no murmurs, does not need an echo.
So the whole drive for this is to try to shift inpatient echoes to outpatient echoes.
So we're trying to decrease the number of echoes ordered.
It's just that we have a reasonable. Go ahead.
Let me rephrase my question.
Sure.
Do we honestly think that any patient who doesn't get an echo in hospital after an acute coronary syndrome with a diagnosis of coronary is not going to get that echo anyway?
Yeah, they probably will, but just.
But he may not need it. Like if it's
That's Eric, I know what you're saying. Yeah. What I'm saying is this really functionally?
Yeah.
This is going to shift an inpatient echo to an outpatient.
No, you may say you may not even order an echo.
But so that's a great thing. I could save $2,000 in a hospital day
and
charge.
an improved flow.
Yeah.
Because over Christmas, when we could do echoes, we discharged how many people? Probably 10 people with a 48-hour admission because of the LV gram. We were waiting for the echo. echo, they would have sat in hospital for 3 or 4 days.
I've sent home STEMIs without their echoes because they have a LV gram, right? I think we all do because in for 3 days they don't need their echo. When you can do it as an outpatient,
Is it level 1 criteria for an NSTEMI to get an echo for the use criteria?
For AUC? Or for, well, it's an acceptable indication. Is that your question? Yeah. Well, that's what I mean. And that's what Dr. Akhtar is getting at, is that these AUC criteria aren't that helpful because they give you permission to order the echo. They don't really say whether it's wrong or right because patients are complex and need echoes for different reasons, right?
But I assume there's some science behind what they've done.
But what specifically, like the echo for the NSTEMI? Oh, well, I think it's a practical guideline recommendation just to make sure that everyone has a ventricular assessment before they leave. Does that make sense?
Yeah, it just, you know that an LB angiogram, this is...
Yes, for sure.
This is 10 of the
Not in a
16
normal,
segments.
though. Not in a normal. That's the whole point. So that's the low-hanging fruit. If you truly have not had an acute coronary syndrome, and you've got an astute clinician that's listened to it, and you've got a grossly normal LV gram, it will not change your management of that patient walking out of the hospital. Sure. Subtle wall.
But I asked for non-STEM.
That's what it is.
Well, and so a small NSTEMI, like Dr. Akhtar was saying, you can apply this rationale to other similar indications like a small NSTEMI, which you're right, you might with some wall motion abnormality. And the specific reason we didn't include these patients is that the driving restriction is different. If you have an NSTEMI with a wall motion abnormality, legally you should be commenting on that, right? So use your judgment, I guess. But non-urgent indications in patients who live near Saskatoon, there's no reason why they can't get their echo as an outpatient. Or recent outpatient echoes. And in fact, I'm glad someone brought that up. I forget who did, Dr. Akhtar. But Amira and the nurse clinicians and the clerks are working together to try to streamline a process where patients get admitted and their chart automatically gets populated with their outpatient cardiologist last clinic note and echo. So in the morning when you see that patient for the first time, you have way more information to go on, which we're hoping will be streamlined. The last project that that I was working on more last year over the summer, which has not gained any traction, so any cardiologist who's interested in being part of it can, but this is an echo requisition which addresses a lot of the issues that we have with triaging. So is the patient on isolation? Is the patient mobile? Have their weight, height, and BMI populated beforehand so you know what you're getting into if their BMI is 50 or if it's 25. And then specifically, do they want a transthoracic or TEE? Because on the order, when you write TTE and TEE can look very similar, especially if you have messy doctors writing, so that's important to know. And then a clear documentation of urgency. So is it emergent? And by the way, if you think it's emergent, you should probably call the echo doc. And so that's written on the rec, urgent or routine. And then there's a note on appropriateness, which we know isn't that effective, but just, nudging people to improve their ordering habits. So if the troponin's normal and you have an ACS, consider, maybe they need an outpatient echo, maybe not an inpatient echo. So this is another initiative that we're not testing yet. Yeah. Yes, it is. It just, that's a really good point. But so.
Why should I have to triage it? Why should I go up on SEM? You make me put that in on my pacemaker.
But that's a good point. Maybe the administrative staff should just be populating that better. Is that what you're getting at? Or?
I know it's down the road, but that information.
But that's the problem.
Yeah.
Automatically, it should
You're
be
right.
populated.
You're right. Yeah, absolutely. Yeah, I agree. And this is probably why this hasn't gained traction. But
echo triage nurse or secretary to open up SEM to start on every patient.
Yeah, it's true.
It's going to be impossible.
I would make a recommendation other than it's emergent and you have to contact the person reading that day to not make it the decision of the ordering physician to decide whether it's urgent or routine. And this is from history. So if you look at requisitions for nuclear stress tests or previous requisitions for CAPs, there are always people who just be putting as urgent as possible because they just want the patient done. So that if you've got a tick list, and then from that, it can be decided in a much more standardized fashion whether it is urgent.
Yeah.
Taking it out of the hands of the person referring.
Right.
The problem with that echo rec, and that comes out of our CAT rec and every other rec, is that who's triaging those? Where's the resource to triage?
but the person who's doing it can still triage by ticking it off. You can actually make it urgent emergent based, like not what you're saying, but it'll actually come out of an algorithm based on those criteria for what is urgent and emergent, right? They can just provide a score. You don't even have to say that.
Right.
Do you know what I mean?
Yeah.
Because I think there is that tendency for people just to say everything's urgent otherwise.
And again, this was just something we came up with. It needs more work, obviously, but it's another potential intervention to address the fact that the person triaging doesn't have much information, and it's a small amount of people in non-invasive trying to guess, whether these people actually need echoes or not.
SCM is going towards the automated order entry system.
Yeah, that's true.
These types of requisitions, if you have to, when you order it, if you have to answer a few questions,
Yeah.
then they work really well.
Yeah.
So the SCM populates all that information that you were talking about, and then it says, well, has this patient had a recent echo or not? And you say yes or no, and then it lets you proceed to the next question.
Well, and that's my big problem with SCM is, I guess I don't know because I've never been engaged to be involved in the design of it, but you would hope that they would go down to non-invasive and ask everybody, what would need to be done. And probably that's being done. I don't know, Crystal and Shelley can attest to that, but... Yeah, okay.
Yeah, in Calgary they had SCM where it's all your order entry. It's all, and the physicians and residents are the ones actually entering all the orders, including lab tests. And when you order an echo, you put in the indication, and then they have a couple other things that you can put that are optional, like if you want to put more information. And all the diagnostic imaging recs for everything you put in, and it's the residents or staff that are putting it in, so you get actual correct indication.
But the thing is, what you're saying is you're filling out a rec.
Yeah.
What I'm saying is that the rec must ask you a couple of questions.
Yeah.
So and then eventually they say, well, based on the information you provided me, it doesn't sound like the echo was indicated. Do you want to override? You could override.
Yeah.
Then if you override, I think that was
Yeah. I just want to leave you with two quotes because we're at the end of our time. So this is, again, Dr. Marwick, who I just really like this editorial, so that's why I'm quoting it. But the overuse of imaging rarely leads to medical harm, which is probably why it's so pervasive. But it is certainly potentially harmful because you're providing an opportunity cost to the medical economy. You're spending money on unnecessary imaging that can't be used for other interventions that may be more beneficial to the individual or community. And he also says this: it's truly extraordinary that although evidence-based medicine pervades medical care, aspects of our professional lives that do not involve therapeutics or interventions seem to remain immune from this discipline. So in other words, we've applied the rigors of RCTs to medications and therapeutics, but have not studied the impact of our work environment or performance on patient care. And so that's really, one of the new frontiers of cardiology. So if I can permit myself to, first of all, thank you for coming. But I think there's a